Hello everyone, I am Dr. Ahmed D. Abdulwahab. I'm a diagnostic radiologist and this is Highlight in Radiology. Last week we decided to talk about the phacomatosis and we said that phacomatosis has multiple syndromes. We decided to talk about only the common ones. We covered neurofibromatosis type 1 and 2 in the last episode. I would recommend that you review it. And in this week episode, we will talk about the rest of the phacomatosis and we'll try to cover it. Before we start, I just want to thank you all for your amazing comments and amazing support and a very nice commitment to watching and suggesting new topics, and we will continue doing that with your support. Don't forget to subscribe and to share the episodes to your friends. So let's start now. Before we go into the other episodes, we will have a quick reminder about the phacomatosis. As we said, the phacomatosis are basically diseases or syndromes that involve the central nervous system, the skin and eyes. Central nervous system, skin and eyes are the diseases that are under the umbrella of phacomatosis, and there are many syndromes that are phacomatosis. However, the most common syndromes and the ones that we are covering here in the last episode, we covered the neurofibromatosis type 1 and type 2, and today we'll try to cover tuberous sclerosis, Sturge syndrome, which is also known as encephalotrigeminal angiomatosis, and von Hipple-Lindau disease, which is known also as retinocerebellar angiomatosis. So these three syndromes, we will try to cover it today: tuberous sclerosis, Sturge, and von Hippel-Lindau. So let's start with the tuberous sclerosis. Tuberous sclerosis, also it has another name known as the Bournville disease. It's multiple benign, the keyword is benign here, tumors of the skin, the eye, and the central nervous system. So like what these tumors, or how can we diagnose clinically, or the diagnostic criteria for the tuberous sclerosis? There is what's called the Vogt triad, which has three findings: seizures, intellectual disability, and adenoma sebaceum. Seizures, on one hand, the seizures, they are not always present. They are absent in about 1/4 of the patients. They don't have seizures. Intellectual disability is also not always present, so up to half of them, of the patients, they have normal intelligence. Adenoma sebaceum, which is basically some papules around the nasal area, they are present in about 3/4 of the patients. So not all patients have all of the findings, but if some patients have all of the findings, then this is a diagnostic for tuberous sclerosis. The radiological findings, we have many manifestations involving many organs. The most common radiologic manifestations are cortical or subependymal tumors or white matter abnormalities, like you can see here. So these are the subcortical white matter abnormalities. We will talk about them in the coming slides. Also multiple renal angiomyolipomas. You can see here there are innumerable renal fat containing lesions, what's called renal angiomyolipomas, and we have on the echocardiography cardiac rhabdomyomas. Cardiac rhabdomyomas, you can see in this echocardiogram, we have this lesion here and this lesion here and here and here. So there are multiple cardiac rhabdomyomas. All of them are very common findings in patients with tuberous sclerosis. So let's talk about these findings in little bit more detail. First, the cortical or the subcortical tumors. 50% usually seen in the frontal lobes. So you can see them at the frontal lobes. More commonly, they are hyper on T2, hypo on T1. You can see like this. This is a FLAIR image, so this is a T2 weighted image. They are hyper intense on T2 weighted image, and only 10% they show post-contrast enhancement. So typically they don't enhance, but about 10% of them show post-contrast enhancement, and they usually after 2 years of age they calcify. Okay, so after 2 years of age they tend to calcify. These are the cortical and subcortical tumors. Now the other finding is subependymal hamartomas. First of all, you can see here this, for example, on this there is a lesion here and a lesion here. These are subependymal hamartomas, and about 88% of them, 88%, they calcify. Okay, usually after the first few months of childhood, they tend to calcify. So they are not calcified at birth. Okay. And they are visible in the first 6 months of age. You can see the subependymal hamartomas here and there. They have, as long as they are calcified, they have variable signal intensity. Usually they are hyper intense on T1 and iso to hyper intense on T2 weighted image. And also here you have to know that the subependymal hamartomas, they have variable enhancement. Sometimes they enhance, sometimes they don't. Sometimes they show marked enhancement or faint enhancement. You can't use contrast enhancement to differentiate the subependymal hamartomas from the giant cell astrocytoma, which we will talk about in the next slide. So, how to differentiate giant cell astrocytoma from subependymal hamartoma? You have to use serial growth, only serial growth. Okay, so if the lesion is growing, then this is giant cell astrocytoma. If it's not, then this is a subependymal hamartoma. So let's continue with the subependymal giant cell astrocytoma. Usually they occur at around age of 8 to 18 years old, and they tend to be large. They demonstrate growth. So if it is growing, it is not a subependymal hamartoma, it's a giant cell astrocytoma, and they usually show intense post-contrast enhancement. You can see in the CT scan, this is the lesion, iso dense, and here it shows intense post-contrast enhancement, and this is what it looks like in the MRI. This is T2 weighted image, of course. So the other finding that we see in tuberous sclerosis are what's called white matter abnormalities. White matter abnormalities, they have, as the name says, they're abnormalities, non-specific. They have variable appearance, sometimes nodular, ill-defined, cystic, band-like lesion seen. They sometimes it's radial bands, like here, for example. You can see this radial band here, radial band here, radial band here. These radial bands are thought to be typical of tuberous sclerosis. The last common finding we see in tuberous sclerosis is what's called retinal phacomas. Retinal phacomas, they are lesions of the eye, of the retina of the eye. Phacoma from phacomatosis. You can see these are calcific spots, two calcific spots here and there, and this is a non-calcified lesion on this CT scan. These are retinal phacomas, and you can see on the fundoscopy this is a calcific spot in the retina. You can obviously demonstrate, see it here. These are retinal phacomas. There are many other neurological findings that we can see in tuberous sclerosis, but they are rarer to be seen. They are less common. First, we see cerebellar atrophy. You can notice the cerebellum, for example, this patient is markedly atrophied with a prominent folia of the cerebellum. This is cerebellar atrophy. Also, you can see multifocal infarcts due to the occlusive vascular disorder. The vessels get occluded, so you end up with multifocal areas of cerebral infarcts or neurological infarct, brain infarct we mean. Also, you see multiple aneurysms, cerebral aneurysms, like you can see in this case. This is an aneurysm. In this MRI, you can notice the aneurysm has a hemosiderin ring. Also, one of the less common or rarer finding to be seen in tuberous sclerosis is dysgenesis of the corpus callosum. As you can see here, these two cerebral hemispheres are completely separated from each other. This is due to dysgenesis of the corpus callosum. You can see in the sagittal T2 the corpus callosum is not barely seen, so it's abnormally formed. It's not agenetic, it's dysgenetic. Okay, abnormally formed. Also, you can see the Chiari malformation. As you can see, this is the foramen magnum and this is the cerebellar tonsil, herniating more than 5 millimeter below the foramen magnum, confirming this is a Chiari malformation. And you can see microcephaly. Microcephaly, we will not talk about it here because we talked about it in the first episode of highlights in radiology. However, you can see this brain here with the normal age-related brain. You can see this is much smaller than this one, and this is the normal brain of the same age. So this is a microcephaly. Also, we can see arachnoid cysts. Arachnoid cysts are a very common finding in brain MRIs, whether it's tuberous sclerosis or not. So this is a middle cranial fossa arachnoid cyst, and as you all know, just a quick reminder, you need to do a diffusion weighted imaging for each arachnoid cyst, because if it shows diffusion restriction, then this is an epidermoid cyst, it's not an arachnoid cyst. While if it follows the CSF signal intensity on all sequences, then this is an arachnoid cyst. Also, one of the rarer findings is a chordoma. Chordoma, we will not talk about it today. In the next episode, we will have some talk about the chordoma. It's a lesion seen usually in the clivus and in the sacrum. And as you can see here, this is a clival type of chordoma. So these are the neurological manifestations that we saw in tuberous sclerosis. Now let's move to the second topic of today's episode of Phacomatosis, which is Sturge-Weber syndrome. It's also known as encephalotrigeminal angiomatosis. Sturge-Weber syndrome has the following findings. It's defined by facial portwine stains and pile angiomas. You have these two findings, facial portwine stains and pile angiomas, and you get what's known as Sturge-Weber syndrome. So what are the classification of Sturge-Weber syndrome? We have three groups or three classes of Sturge-Weber syndrome. It's type 1, type 2, and type 3. Type 1, it's the classic syndrome. They have facial and leptomeningeal angiomas, may have glaucoma, while type 2, it's a peripheral type. They have the facial angioma, no intracranial disease, also may have glaucoma. And the type 3, that's the central type of the Sturge-Weber syndrome. They have leptomeningeal angiomas and no glaucoma. So it's either classic syndrome, type 1, or type 2. They have the skin, not the brain, or type 3, the brain, not the skin. Okay, so these are the classes or types of Sturge-Weber syndrome. So let's start with the radiologic findings. On the CT scan, we have subcortical calcification, associated parenchymal volume loss. You have the subcortical calcification like that, with like this is the early stage and this is the late stage, and you can see the associated parenchymal volume loss. You can the patient started like this, and then he had this abnormality. You have also what's called the tram track sign, as you can see here on the bone window. It's very obvious. You have two tram track like this one, two lines parallel to each other. This is what's called tram track sign. It is very typical of Sturge-Weber syndrome. And you have what's calvarial and regional sinus enlargement. You can see the calvarium of the brain is very thick and enlarged, okay, and even the sinuses should be prominent in these cases. Also, you have ipsilateral choroid plexus enlargement. You can see the parenchymal volume loss here. This hemisphere is way smaller than the right one, and you can see the choroid plexus big and prominent here. Also, in severe cases, you might see what looks like a Dyke-Davidoff-Mason syndrome, or Dyke-Davidoff-Mason appearance, which is hemicerebellar atrophy, hypoplasia, and it's accompanied by compensatory osseous hypertrophy and contralateral hemiparesis. Basically, this part of the brain atrophies while the second part, the normal part, gets hypertrophied to compensate. While this seen usually in children or in neonates with congenital cerebral infarction leading to atrophy of one half of the brain, one hemisphere of the cerebrum, and hypertrophy of the second hemisphere of the cerebrum. Now, the other findings is also orbital choroidal hemangioma. You can see here orbital choroidal hemangioma, the thickening and the pattern of enhancement. It's in the choroid, and this is known as orbital choroidal hemangioma, and asymmetric cavernous sinus enlargement. As you can see here, this is the normal cavernous sinus, and this is the abnormal cavernous sinus, thick, enlarged. This is also one of the findings that we see in Sturge-Weber syndrome. While in MRI, let's compare the findings on the MRI. On the T1, it's largely normal, the affected part. You may see volume loss in the advanced disease, but all in all, they look normal on T1 weighted image, especially before volume loss, okay? On T1 with contrast, you will see prominent leptomeningeal enhancement, as you can see here. The leptomeninges are enhancing in the affected area. Why? Because the veins in the area are congested and they result in venous congestive ischemia and infarction with obliteration of the cerebral parenchyma. Basically what we have is an early stage of venous infarct due to the congested cerebral veins. So you'll have leptomeningeal enhancement. While on the T2, of course, this is also again the prominent leptomeninges, and you can see the enlarged choroid plexus as we discussed in the previous slide. And you can see here, these are the veins that are congested and prominent, and the affected part of the brain is smaller in size, as we said, and these are all findings that we see in Sturge-Weber syndrome. So regarding the last type of phacomatosis that we will discuss is the von Hippel-Lindau disease. Von Hippel-Lindau disease, it's what's called retinocerebellar angiomatosis. So there is development of numerous benign and malignant, while in Sturge-Weber they were only benign. Here we have benign and malignant tumors in different organs. So it's at least 40 types of tumors. So we have a lot of tumors that develop here. So we will take a quick look about the common and the important one. Let's start with the abdominopelvic organs. First of all, in the kidneys, the renal, we have renal cell carcinoma, and they are frequently bilateral. You can see in this CT scan image, there's this ugly looking tumor, and it's very typical of renal cell carcinoma. And we have renal cysts. The renal cysts tend to be bilateral, tend to be multiple. Like you can see in this MRI image, there are multiple, innumerable, bilateral, variable size. They can be simple, complex, or even cystic renal cell carcinoma. So we have to be careful with these tumors. Also, we have multiple renal angiomyolipomas. As you can see here, there are multiple fat-containing lesions in both kidneys, and they are typical of renal angiomyolipomas. Also, the other finding is in the liver. We see liver cysts, can be solitary, can be multiple. This is another very nice demonstration of the combination of renal cyst with renal cell carcinoma that's bilateral. Okay, so now let's go back to the liver. We have the liver cysts here. You can see, can be simple, can be multiple, can be just a single liver cyst. So liver cyst is also one of the findings in Sturge-Weber syndrome. In von Hippel-Lindau disease. I'm so sorry, the von Hippel-Lindau disease. Now, regarding the let's continue with the abdominopelvic organs. We have the adrenal tumors, including the pheochromocytoma, which can be in the adrenal gland, or it can be extra-adrenal pheochromocytoma, like example in this case, what's called also paraganglioma. The extra-adrenal pheochromocytoma is also known as paraganglioma. Regarding the pancreas, we have several findings that we see in von Hippel-Lindau disease, including the pancreatic cyst, as you can see here. Pancreatic neuroendocrine tumor, they are usually non-functional, and they are frequently multiple, like you can see here. This is a large pancreatic tumor, indicating it's a pancreatic neuroendocrine tumor because it's non-functional, so it does not cause symptoms. If it was functional, like for example gastrinoma or insulinoma, they would be discovered very small size, but they are non-functional. That's why they are of large size. Also, what other findings we have is the pancreatic these are also multiple pancreatic cysts, innumerable. I think we saw a case in our presentation with the residents case discussion a few weeks ago. Innumerable pancreatic cysts of von Hippel-Lindau syndrome. The pancreatic serous cystadenoma, it's a benign tumor composed of multiple small cysts. Here, as you can see, this is the pancreas, and it's in the body/tail of the pancreas. This is the maximum intensity or the MIP image of the case, and in the CT scan also you can see here in the head of the pancreas, that's another patient having multiple small cysts, suggesting pancreatic serous cystadenoma. Pancreatic adenocarcinoma, rarely seen in patients with von Hippel-Lindau, but they are a finding. You can see here, this is the pancreatic the pancreatic adenocarcinoma. It's a very typical CA head of pancreas in the region of the head with possible invasion to the adjacent small bowel. Now, what other features do we have in von Hippel-Lindau? We have the urogenital findings, including epididymal cysts. It's simple diagnosis of cyst in the epididymis, and you have a kind of a benign tumor seen in the epididymis known as the papillary cystadenoma of the epididymis. You can see this is the head of the epididymis. It's complex, it has some mass-like lesion with cysts, maybe even small calcific foci here and there, and this is what's called the papillary cystadenoma of the epididymis. And there is something rare, and it's nice to see a demonstration of it. This is called the broad ligament cystadenoma. Broad ligament, of course, this is in female patients. It looks very commonly looks like an ovarian cyst, but if you look carefully, it is in contact, not arising from the ovary. And you can see here, this is the broad ligament, and this is what's called broad ligament cystadenoma. It's also one of the findings that we see in patients with von Hippel-Lindau disease. Regarding the central nervous system, we have the what's called the CNS hemangioblastoma. Hemangioblastoma are very typical findings in von Hippel-Lindau disease. Usually can be seen in the cerebellum or in the spinal cord, and the spinal cord most commonly in the cervical or thoracic cord, and it also can be seen in the brainstem. This is an example of hemangioblastoma. It's a cyst with a mural nodule, and the nodule shows intense post-contrast enhancement. As you can see in this digitally subtracted conventional angiography, you can see there is a nodule that is very marked enhancement. This is of course cerebellar type, and you can see the brainstem type is basically the same. You have a cystic lesion with a mural nodule, and the nodule shows intense post-contrast enhancement with surrounding myelomalacia or syrinx, whatever you want to call it. Also, we have a brainstem type. This is the brainstem type. It's also the same feature of cyst with a mural nodule that shows intense post-contrast enhancement. Also, we have what's called the choroid plexus papilloma, and I will not discuss it in details. However, it's a lesion in the choroid plexus showing marked severe intense post-contrast enhancement with dilated ventricle due to hydrocephalus caused by overproduction of CSF from the papilloma. So in the head and neck, what do we have in von Hippel-Lindau disease? We have the retinal hemangioblastoma. So this the same hemangioblastoma, but it's in the retina, and this is the most common presenting feature because the patient have some visual abnormality and come for to know what's wrong with him. Retinal hemangioblastoma is the same as the hemangioblastoma in the brain. You have a cystic lesion with an enhancing mural nodule. So you can see here, this is the cystic part and the mural nodule part. And the other finding is the endolymphatic sac tumor. It's bilateral in 30% and it's considered pathognomonic for VHL. If you can see the endolymphatic sac tumor, especially if it's bilateral, you can diagnose VHL confidently. As you can see here, this is the small lesion that is the endolymphatic sac tumor. Also, you can see it here. And in the CT scan, you can see the erosion, that is the endolymphatic sac tumor. So this is the end of our talk about the phacomatosis. I hope you like it. I hope I was thorough, but not wasting your time. Please tell me, what do you think? What are your thoughts and comments in the comment section in the YouTube? And thank you for listening, and please don't forget to subscribe to the channel and tell me what should we do next. By the way, wait us for in the next Friday at 5 p.m. Baghdad time with the new episode of Highlights in Radiology. It will be about vertebral lesions, tumors, and lookalikes. It will be very interesting. We have a lot of abnormalities that we see in the vertebra, mass-like lesions or masses, and we need to know what they are. Keep waiting, and don't forget to subscribe. Thank you. I am Dr. Ahmed D. Abdulwahab. Bye bye.